Hi, my name is Craig Cito. I'm one of the family practice physicians here at UVA. Today we're going to talk about the clinical knee exam. We're actually going to do a demonstration of that. I have with me, helping out, this is Jay Zimmerman. He's one of our fellows here at the family practice department. When we talk about the clinical knee exam, I think certainly the most important thing we need to remember about that is that we want to have a knee exam that we can repetitively do and methodically do every time we see a patient who comes in with knee problems. As far as the setup of getting ready to do the knee exam, we want to make sure that we have a well-lit exam area. We want to make sure that the patient has clothes on that appropriately expose the knees, as well as the upper part of the thighs where we can see the quadricep muscles. And then we want to have a table that allows the patient to sit as well as lay back and allows you room to maneuver on either side. Now the basic knee exam consists of 4 parts. The first part is the inspection, second part is palpation, then your range of motion, and then we'll do ligamentous testing and some special tests after that. And we're going to break that up and take that one by one. The first part of the knee exam is going to be the inspection, and there's a lot of good information that we're looking for when we're inspecting the knees. We're going to be looking at the knees primarily, number one, for scars, any focal areas of swelling, and certainly we're looking to see whether there's any evidence of an effusion or fluid within the knee, and frequently up around the suprapatellar area in the suprapatellar pouch is where we're going to see fullness if there's fluid within the knees. Right now we can see very well the patellas that are demarcated here, but if there was fluid within the knee, we would lose the superior border of the patella. Other things we're looking at is we're looking at the position of the patella. When we're sitting at 90 degrees, just with the knees bent here, the way Jay is, the patella should be facing relatively forward, almost like the lights on the front of your car. They shouldn't be angled out, but they should be relatively facing forward. The other way that I like to do inspection is to have the patient stand up. And Jay, I'll have you stand up right now. And put the feet together. And with Jay standing up like this, now we can look at his legs and get a sense of what the alignment of his legs are. And that means, are Jay's legs relatively straight? Do they have a varus posture where they're somewhat bow-legged? Or does he have more of a valgus posture where he's somewhat knock-kneed? And as I look at Jay's legs, he has just a very slight varus alignment. I then look at his patella again and see which way they are facing. And Jay's patella, actually, the right patella, as well as a little bit on the left, seems to face inward, which tells me a little bit about a rotational component, and that's primarily taking place up at his femur, what we call femoral anteversion. Other things I'm looking for is symmetry of the quadricep muscles. So I look at the muscles of the thighs, and I would hopefully expect them to be fairly symmetric. If you've had an injury on a knee before, usually the thigh muscle will shrink down and be much smaller than the other one. And I think that's all we really are looking for on inspection. One additional aspect of the inspection process can be allowing the patient to actually walk out in the hallway and have them walk down the hallway, turn around and come back, and they can do that several times. And that will give us additional information of how their knee is working when they're actually biomechanically walking down the hall. So we're looking to see whether they are limping, whether there is any abnormalities in movement of their legs, and it can be very helpful, especially in people who are such as runners who come in with long-standing knee pain that comes especially when they're running. So Jay, I'm going to have you walk out here and walk down to the end of the room, turn around and come back, and then we're going to do that several times. And as Jay does that, I'm basically making sure he doesn't have a limping gait. I'm also looking at the kneecaps and seeing what they're doing. I'm watching the quadricep muscles and making sure they're firing symmetrically. And also we can look down at his feet and make sure that he is not hyperpronating, which he does not appear to do. Okay, thank you, Jay, and you can have a seat back on the table. After the inspection portion of our exam, we then go into the portion of our exam which is called palpation. And this is a very important part of our exam because if we can palpate a structure and we know what that structure is, we can almost come up with a diagnosis of that. I think it's very important that we palpate in the same general way each time we palpate the knee, and we do that systematically so that we don't forget to palpate certain structures. I'll show you the way that I do that so that I try not to forget the structures to palpate. I'll usually start with Jay. If this was his symptomatic knee on the right side, I'll come and start down at the tibial tubercle and press on that. Frequently it can be irritated with Osgood-Schlatter's. Right above that is the patellar tendon, and I'll give it a good mash, and if that was tender, we'd have patellar tendonitis. Above that area is right in front of the patella, and there's a bursa that lies here, the prepatellar bursa, and that frequently is injured when you fall on your knee or in wrestlers or people who spend a lot of time crawling on their knees. Above that is our quadricep tendon, and frequently can get inflamed. I see this a lot in triathletes, and if they're tender with palpation, you've got a diagnosis right there. I then will palpate around the area of the knee, knowing that on the medial side, where I call the parapatellar area on the medial side, is a structure called the plica, and the plica is a synovial fold on the inside of the knee that frequently gets irritated in runners and people with anterior knee pain. All you have to do is rub over this area and it can be very tender. I'll then come down on either side of the patellar tendon where my thumbs kind of naturally fall into these little indentations, and I'll find the joint lines on either side, and I'll palpate along the joint line, usually with my thumb, and I'll march the joint line all the way around medially, and I'm feeling and seeing if there's any tenderness. Tenderness would indicate meniscal pathology. I'll do the same on the lateral side with my thumb and march it all the way around. And I'll also remember that the meniscus go posteriorly, so that a posterior meniscal tear will cause pain on the back side of the knee in the popliteal area. So I'll frequently just kind of compress in the popliteal area. I also understand and remember that a Baker's cyst can also exist back here, and I'll feel for any evidence of swelling that would indicate a Baker's cyst. After that palpation, I'll have to remember that right down here, if we go from the tibial tubercle and go medially, there's the pes anserine bursa, which is a bursa that frequently causes medial knee pain. And if you forget to palpate it, then you'll miss that diagnosis. The last thing I do with palpation is then I'll look up at the quadricep muscles again. Remember, we looked at it for symmetry. Now I'm going to palpate for symmetry in the muscle tone. So I'll have him straighten out his legs, fire those muscles real hard, and I'm going to palpate both of them at the same time. I'm looking at the size and the tone of the quadriceps to make sure that they should be symmetric. Okay, thank you, Jay. And that's the majority of our palpation. Okay, this is the part of the exam where we're looking at the range of motion of the knee. Now, the range of motion of the knee, it is a hinge joint. It goes from 0 degrees, where it is fully extended, and I like to a lot of times have them lay down and examine both sides, both knees, because if you have an effusion in the knee, a lot of times that will limit the last couple degrees of full extension, so you'll have somewhat of a flexion abnormality in a knee that has an effusion. I'll then bring the knee up if it fully extends, and I understand that it should flex to at least about 135 degrees. Again, a knee effusion will cause it to feel very tight, and I might not get this much flexion. Also, meniscal pathology or meniscal tear will cause pain if I flex down like this, because we're compressing the meniscus between the femur and the tibia. But as long as they can do this without pain, then they have normal range of motion. So this is 0 degrees to 135 degrees. The next part of your exam is going to be the ligamentous testing, And again, I tell students and residents that we do ligamentous testing to check for injury to the ligaments. And based on the history, we'll decide whether we're going to do that portion of the exam with a certain patient. If they have no history of trauma to their ligaments, then it's probably not a helpful piece of the exam to do. But I'm going to suppose that, that Jay had some injury to his ligaments, and we want to make sure whether one is looser than the other. While he's sitting here, I'll usually check the medial collateral ligament first. He's at 90 degrees here. I'm going to extend his leg all the way out, and if you'll see my hand placement down here at the base right above the ankle, and I give it a very good firm grip so he doesn't internally or externally rotate. I keep it very firm. I then use the palm of my hand as a fulcrum on the lateral joint line, and these are my two contact points, and then I gently give him a valgus stress, and I'm trying to open up this joint by pulling this way. And if the ligament is intact, I should not be able to open the joint line. If you can open it, you should feel a good end point if the ligament is intact, but is just a little bit loose. People have different laxities of their ligaments, so if you feel like a ligament is loose on this side, then you need to compare it to the contralateral side, because if it's the same way on the other side, then that's a normal exam. So I'll come down, full extension, and then I'll also bring them down to about 30 degrees, and what that does is it makes the ACL and the PCL ligaments inside the knee relax. And then I'll re-stress him, and this time you'll get a little bit more movement, but you should still have a very firm end point. I'll put that down, and then I'll come around the knee. So testing the lateral collateral ligament, I'm going to come down and put, again, taking a look at my hand placement above the ankle very firmly, and then the palm of my hand on the medial joint line at full extension. I'm going to stress him, give him a varus stress. And you can see he really doesn't open up. He's got a firm end point there. I'll then bring him down to about 30 degrees. And you can see he opens up a little bit more, but still has a very firm end point. And if I had any questions whether that was abnormal or not, I would then check the contralateral lateral collateral ligament. I'd come on the other side and make sure that that was symmetric in the way that it felt. To evaluate the two ligaments that are on the inside of the knee, the ACL or the anterior cruciate and the PCL, the posterior cruciate, we have two other maneuvers that we'll do here and demonstrate. To evaluate the ACL, there are two maneuvers I'm going to teach today. The first one, being the simpler of the two, is called the anterior drawer. With the patient laying down, I'm going to flex his knee up to about a 90-degree angle, and then I'm going to tell them that I'm going to sit on his foot and stabilize it. Now, the ACL will prevent us from actually transisting or pulling his tibia forward. The ACL will hold the tibia stable and not allow me to transfer it forward. The PCL prevents me from translating it backwards. Okay, so in this position, I'm going to sit on his foot. I'm going to feel for his hamstrings and ask him to relax these muscles here, because they would give you a false negative test. I'll take my fingers, grasp behind, and give him a quick, sharp pull forward, and I'm feeling for how much his tibia translates forward. And he moves a little bit, but he's got a pretty good end point. The posterior cruciate ligament will not allow me to push the tibia backwards, and this is what is called your posterior drawer. I then will take a look at the ACL one different way, and that's with the Lockman's maneuver. And the Lockman's maneuver takes advantage of the fact that if you take the knee and, while he's relaxed, flex it to about 20 degrees, all the other ligaments in the knee become very lax, and that they're at their most relaxed position. And at this point, with him very relaxed, I will then grasp the lower part of his femur and the upper part of his tibia, and I'm going to try to translate his tibia anteriorly very quickly. So I'll give him a quick jolt. And what I'm feeling for is I'm trying to feel the ACL snap like this, like my finger. So if it's loose in there and it's intact, when I pull up like this, I'm going to feel a very sharp catch, which I definitely do with Jay. It's got a very good end point. And if you can do this appropriately and correctly, this is a much more sensitive test for the integrity of the ACL. The next portion of our exam is going to be testing the meniscus for any tears or pathology. We're going to demonstrate the McMurray's maneuver, which takes advantage of the fact that when you flex the knee up in this position, you're compressing the meniscus between the femur and the tibia. And the way the meniscus usually gets injured is with some type of flexion activity with a twisting component to it. So you flex and you twist. So McMurray's maneuver takes advantage of that same mechanism to see whether we can cause the meniscus to either cause pain or to cause a little bit more of a shearing or tearing of the meniscus and some clicking sensation. The maneuver is somewhat demonstrated and described several different ways, so I'm going to show you one of the ways it's described with, again, taking my hand down here right above the ankle, firm grip, and we're flexing him, and that's the most important portion here, flexing, and then I like to have it internally rotate, and then we're going to extend, keeping him internally rotated with a little bit of valgus pressure here. I'll do the same thing again, and you can repeat that one more time. And what we're feeling for is, do we get any pain around the joint lines or feel any clicking? You then can reverse that by flexing and externally rotating, and you can extend them again with a little bit of varus pressure, and do that several times. And a positive test would be if the person complains of pain along the joint line, or you feel a click or a palpable click on the joint line as you're doing that. Okay, the last portion of our exam is going to evaluate the patellofemoral joint, and the patellofemoral joint is the patella as it's sliding up and down inside the trochlear groove of your femur. And because of that constant motion through life, there gets to be a lot of wear and tear underneath the patella. One of the ways I like to feel how much wear and tear is there is just by putting them through an active range of motion, by bringing them up, flexing them, and what I'm going to do is place my hand right above the patella with some pressure over top of it, and then flex and extend his leg up and down. And what I'm feeling for is to see whether there's any cracking, popping, or crepitus underneath the kneecap. And I should feel the kneecap stay within the groove itself. I shouldn't feel it right over to the side or onto the medial aspect. So it should be a nice, smooth, gliding motion. Once I've done that, I'll put them into extension and have them relax. And if there was any problems with the patella staying within the groove, one of the ways we can evaluate that, or what we call patellar instability, is that we will take our fingers on the medial side of the patella and try to push it laterally. With patellar instability, the patella usually always seems to sublux or come out of the groove onto the lateral side. So actually pushing laterally to see if that will happen, and seeing if that causes apprehension in our patient. And Jay doesn't have any apprehension doing this. The last part of my exam, when I have them like this, I will check out their, the flexibility of their hamstring. The way I do this is I will then lift them up into this position where the hip is at 90 degrees in flexion and the femur is perpendicular, and then I'll slowly raise up their tibia till I feel resistance. And then I estimate what is the degree from totally perpendicular that I can get his leg. So I'm looking at this degree right here, and Jay's probably looking around 70 to 75 degrees. If I could get him all the way straight, he would be 0 degrees and he'd have very flexible hamstrings. So Jay's got fairly tight hamstrings on today's exam. We just completed reviewing the clinical knee exam. Now, what we need to remember about that is that before we do the exam, we're going to take an appropriate history, and hopefully during that history be able to identify the mechanism of injury of what has caused the knee pain in the first place. Based on that mechanism of injury, we'll be able to either take out a certain part of the exam, or if it's unclear just what's going on, we'll do the entire clinical knee exam. Certainly we're going to remember it always starts with inspection. One important thing we're always looking for is evidence of effusion. If they have an effusion, that tells us something is internally damaged within the knee. And remembering what structures those are will help you hone in on your diagnosis. Palpation is also very helpful, especially if there is any tenderness, inflammation, or problems with the bursa. If you can palpate that and it's tender, then you have your diagnosis right there. If they have a significant trauma to the knee, as in sporting activities, then ligamentous testing is going to be very important. Certainly if they have a history of bending and twisting and then injuring the knee, we want to look at the meniscus, and we'll do that through palpating the joint line and the McMurray's maneuver. Certainly at the end, after you've done an entire clinical knee exam, you've had a good history, then you should have a very good idea of what the diagnosis is, and you'll base your treatment on that diagnosis.